Good afternoon to everyone coming on. We'll just give it a few minutes to make sure everybody can log in, and then we'll get going with today's session. Right, we'll start, I think. We've got quite a few people logging on. There may be a few more coming in later on. Good afternoon, everybody. Welcome to our second in the series of our palliative care webinars. There's still time to book on to the other 3 sessions. If you just click on the same booking link you used for today's, then you should be able to log on. Just some housekeeping before we get going. We've got the chat function and the Q&A available at the bottom. And if you want to chat with the team, please use the chat function. If you've got any questions you'd like to post to Fiona and the team at the end, then do type them in there. We've got a few panelists for you today. We've got Fiona, who's deliver the session. We've got Emily, who's going to give the GP perspective, and we've got Karen and Alex, who will give a nurse perspective. That's enough from me, I think. I'll hand over to Dr. Fiona Rawlinson. Enjoy the session.
Great, thanks, Charlotte. We're really excited to be able to deliver these sessions, and you're very welcome from wherever you are joining us from. As we said, this is part of a collection of 5 that we've really developed to help support palliative care issues this year particularly, and obviously with relation to coronavirus. So the team have put together is myself and Joe Hayes, Emily and Sian and Charlotte, and we're delighted, as we say, for Karen to join us today. So through the talk today, it's quite difficult as a webinar, and those of you who know me know that I'm an interactive, getting groups together sort of person. But we've got the question and answer part, but we're also going to be posing occasional kind of comments and questions on the chat function, really to get you thinking about your practice in advanced care planning, and particularly it's those advanced care planning conversations. So I want you just to picture somebody. It could be somebody who you've had an advanced care planning conversation with this week. If you're new and here because you want to know more about the topic, you could think about a lady like this one. She's 65, she's got worsening pulmonary fibrosis, which makes her very breathless, makes her very anxious. And when she gets anxious, she calls 999 because she lives on her own, and she's globally deteriorating as the year has gone by. And so questions are being asked about actually, you know, it's a big upheaval for her to call the paramedics. Sometimes she goes into hospital, sometimes she doesn't. But there's a lot of kind of busyness around her care, and the question is, could that be improved in any way? So the aims of this webinar this lunchtime is to think about the issues around addressing some of the advanced care planning needs, and really to discuss the strategies to support the conversations. And I think probably the first thing to do is just to break off for a moment and just check who we are lucky enough to have joining us today. I can see the number of participants, including ourselves, is 75, which is a fantastic number. So Charlotte, I wonder if we could just do that first poll just to see. So can you just let us know where you are? What's your main role? You might have more than one role. So what's your main role? Fantastic. Okay, we're nearly there. This is really exciting, lovely. So we've got some GPs, GP trainees, district nurses, ambulance service, palliative care team, allied health professionals, a doctor from another setting, and other. We can't have a free text box, sadly. That's fantastic. Charlotte, can we launch the next question, number 2? And so this is just a question, where are you from? And we got, and again, apologies, people. As you can see, the chances are it was Wales, England, Scotland, Northern Ireland, Europe, and somewhere else. Apologies, somewhere else, people. We couldn't put the whole countries of the world there, but thank you. So the majority of you are from Wales, a few from England, a few from Europe, and a few from elsewhere. That's lovely. And then Charlotte, the last of the 3 questions at this point, please, and in what setting, just asking where you're working. Which is, again, and this is really just to give me a feel for where the group is. So, Charlotte, I don't know if it's possible when we've cranked up the numbers, probably that's about it. Is it possible for you to share those results?
Yeah, everybody should be able to see those.
Everybody should be able to see them. That's fantastic. Lovely. Fab. Thank you. So we can stop sharing the results now, which I'll do that. So the thing, just trying to get us, the screen looking a little bit better, that's better. So we are based here in Wales. This session this week is very much more around conversations rather than specific processes, but depending on where your work and where your background is, some of the things that I may talk about, that we may talk about, may be slightly different in your setting in terms of the process of, for example, recording conversations or storing conversations. So what I need you to do is just to take the learning points, if you like, from it, and to think about, in my setting, how would this be different? But just before we really get going, just have a little thought for, in this area of your practice, what is it about advanced care planning conversations that you find challenging, or what might you want to know a little bit more of, just so that you can kind of process some of the information that we're going to be talking about. So if we think about Our Lady, again, I think some of the easiest way just to think about ACP is just to do the what, when, why, how, who, and to really think about it in those terms. So we're going to talk about advanced care planning as a concept. I'm not talking specifically about advanced directives or advanced statements, although our conversation might bring some of those in, but we're talking about the planning. It's really important to think about what that is. So advanced care planning is not just a document. Documents can be helpful, but advanced care planning it's that discussion. It needs to be about that person-centered discussion. Yes, filling documents in, recording people's wishes is important, but actually you need that discussion first. You need to think about really the type of treatment and type of care that the patient would or wouldn't wish to receive in the event that they lose capacity, etc. One really important thing to emphasize is that we're talking about treatment and we're talking about care. And you hear people say, we need to discuss about the ceilings of care that people would want. I think we need to get away from that term, because there should be no ceiling of care. And I think sometimes some of the anxieties that people have in discussing these issues is that they don't want to think that their care is going to disappear and that they're going to be alone without people to care for them. So advanced care planning and escalation plans, etc., about ceilings of treatment that people might endeavour to need. So that's just a little bit of language. We're talking about ceilings of treatment. We're not talking about ceilings of care. So I think if you hear people talking about ceilings of care, you need very gently to correct them. That care is still going to be there. With coronavirus, it might look a bit different, but it will still be there. But what actually we're talking about is some of the treatments that you may or you may not want. And so examples could be talking to people about preferred place of care, talking to people about preferred place of death. Those are two different things and not always the same place for people. And I think, again, that's an assumption that sometimes, particularly when you're reading documents around it, sometimes people are not making that distinction, and it's a very important distinction to make. Sometimes examples could be wishes regarding possessions, for example, a will, or wishes regarding people, perhaps dependents, And perhaps one of the most important things is actually who will be my advocate if I am unable to express my wishes. I think for a lot of people, they are very worried about that sense of loss of control. And if they're unable to speak, then who will know? Who will know what it is that I want or don't want? So those are just some of the examples around advanced care planning. And I know that all of you will be able to think of other things for where you work. Let's just think for a moment, though, about your own experience. So again, Charlotte, can we have the next poll, Elise? So what we need to know, the group needs to know, is, do you have conversations around advanced care planning issues in your work? Again, just to give a sense of the need, if you like. That's wonderful. We're very nearly there, aren't we? So 85% of you, roughly 86, have advanced care planning issues, have conversations. Thank you. Can we go to the next question, please? And so this is just about your confidence in managing such a conversation. And I think people's confidence changes partly according to how many you have and how many variations of the conversation you've had. So I've had ACP, advanced care planning conversations, which have gone hideously badly for reasons sometimes which I'm still a bit mystified. Mostly I think they go okay, but just sometimes you get surprises. And I think using reflective practice as a way of thinking about how things have gone is a useful top tip. That's great, thank you. So we've got quite and mostly, and a few very, and some not at all. That's lovely. Can we have the next question, please? There's 3 more to go. So, it's all anonymized. I don't know who you are, but just a question if you've made a will or not. Really interesting question, this. I'll tell you why it's really interesting in a moment. That's wonderful. Okay. Thank you. So more people haven't made a will than have made a will. That's great, thank you. Can we have the next question, please? 2 more. So in your world, do you know what the wishes are of those who are important to you? So if something happened, and please God it won't, but if something did happen to somebody close to you, do you know what their feelings are? That's really interesting too. So yes, a little bit more than no. That's wonderful, thank you. And one last question, which is for you. So if you have something serious happen to you, have you talked to those important to you? Okay. So about 43, so 45% no, 43% yes, straightforward, and 12% yes, but it was difficult. Okay, Charlotte, thank you. That's really helpful. So the reason just for asking those questions that became just a little bit tricky, I think, possibly for some at the end, was actually just again to help us focus on what it is we're doing in advanced care planning conversations. And if we are helping to support people talk about some of these difficult things, if we haven't gone through that process ourselves, then sometimes, although we are all very experienced practitioners, sometimes it can be a little bit difficult to understand why potentially sometimes those conversations are not always straightforward. And our findings, just in that very simple poll that we've done today, very closely match the findings in a Dying Matters survey, oh gosh, now probably 2017 or 2018. And it was found that actually over half of it was general practitioners who were surveyed, around advanced care planning issues hadn't themselves made wills and hadn't thought about their own wishes. So this is just a kind of a flagging up. It's just, it is a useful area. It is a useful area to think about. I think this year particularly, with coronavirus, it has perhaps made people begin to think a little bit more about what they might or they might not want. It's very difficult, isn't it? If you're feeling in reasonably good health, it's very difficult to imagine a time when one isn't. And you could argue that actually it's not necessarily appropriate to talk about a time when I'm not going to be so well. I think the only difficult thing is that sudden events can happen too. And so perhaps there is something about sharing one's own thought with people who are important to you. So that's the experience of us here in the room. And then just thinking about actually, what do we know? What do we know about the process of planning for the end of life? What research has been there? Well, actually quite a lot of research has been ongoing about it at the moment. There's a particularly interesting survey from 2013, which I think I'm sure is going to be being redone from Europe as a result of the coronavirus wishes. So Richard Harding and colleagues from London in 2013 were part of what was called the PRISMA study, asking, and this was just part of a big study around end-of-life care. And they asked people the question on the phone, if you had less than a year to live, would you want to know? There's methodological things to think about in the study, which we haven't got time to do here. But they asked over 9,000 people on a telephone survey across 9 countries in Europe. So that's quite big numbers. To cut a long story short and to simplify, people were more likely to want to know if they were aged under 70, if they were male, if they had an experience of illness, or if they were more highly educated, had got a higher level of education. And interestingly, about 21% said they didn't want to know, or they didn't want to know unless they themselves asked for that question. But there was also country variation in what people might want to know. But the majority, that there was definitely a feeling, if you were under 70, if you were male, if you were educated, if you had past experience, then very definitely people would prefer to have more facts. It helps planning, for example. You can look at the number of people who die without making a will, for example, round about, depending which figure you look at, round about 60% in 2018. That's a big number of people who have died without making a will. So their families don't, their possessions, their families, all their organisation hadn't been able to happen, and that leads to all sorts of complications, which I'm sure some of you know more about in terms of actually first-hand experience. And the other research that's happening is research on the conversations. So actually, what words and strategies will people use? And there's some very interesting research coming out of Ruth Parry's group, who have set up a group called Real Talk. So if you Google Real Talk, they particularly put some very useful resources for having ACP conversations quickly in a time of coronavirus. I've got a slide with the websites and the names at the end. But they did a systematic review about the sort of conversations that seem to help and the sort of things which seem to hinder conversations around advanced care planning, and allowing for the fact there was a big variety in people's practice. If you ask sort of fishing questions, so fishing questions were the very open questions that we're all taught to ask to get conversations going. Things like, are there any issues you'd like to discuss, for example? So not very specific, just a big open question. And what they found was that actually it seemed that those were easy if you were somebody who didn't want to engage in advanced care planning conversations. You could deflect those quite easily. And I can think of people who I've looked after very definitely who prefer not to go there, thank you very much. If you try and maintain hope, which is something that we all try and do, and keep a fairly optimistic approach, it can be a very useful short-term strategy, but potentially it prevents people from addressing the bigger, more serious issues as they approach. So it's not to say it's wrong at all, but it just, I think one needs to know that if you use that approach all the time, potentially we're closing off opportunities to enable people and to support people to talk. The sort of areas that seem to help the most are using hypothetical questions. So that would be something like, some people will find, or have you ever wondered? It's about talking about things that haven't yet happened, but that might happen, but in a sort of a very general way, but then also listening to what the person is saying and responding to the cues that they might give. So you really need to kind of be on the high alert for anything that might open the door to having an advanced care planning conversation. But this is an open access article, so again, I would really encourage you to read it, because it gives you some really nice examples as well of some of the questions, and how, you know, every conversation that we have with people is different, isn't it? And every conversation we have with the same person is different. So you might use different strategies each time, but I think we need to know what the impact is of those strategies. So I'm just going to pause just for a moment, and Sian, do you want to just pop this first question on the chat function, which is just, okay, so why is it important? What happens if there is no ACP? And I'm just going to open up the chat function, I hope, on my computer, just to see. So yeah, so what happens if there's no ACP? Just write your thoughts there. Write your thoughts there. Because you could argue, well, you know, actually, does it matter? Does it matter? People die comfortably without having ACP conversations. But lovely comments coming up. Uncertainty, potential harm to patients. It gets complicated, definitely. Confusion, people and family members are not aligned in the same way. Disagreements, unwanted treatment. Confusion, conflict, panic. That's really powerful, isn't it? That's really powerful. Fab. Keep your thoughts coming. Thank you. Because the chat we can record and we can send out as well. It's part of the talk. And just again, to summarize, what could it be? It could be problems for the patient, either physical symptoms are not addressed, perhaps psychological symptoms, the whole holistic care approach. It can avoid burdensome interventions. It avoids, where possible, unnecessary added stress. If people are trying to make decisions about their place of care from a situation of high drama, high stress, high crisis, sometimes those decisions will not have necessarily had the time to be able to be thought through. And then in terms of people's bereavement afterwards, which we'll come on to 2 weeks today, it can make life more complicated. So trying to encourage people to use a calm time just to think calmly and logically without too much anxiety can help people feel enabled, really. I've put resource implications at the bottom with a big capital letter caution. I think COVID has really taught us some of the very difficult bits about advanced care planning, hasn't it? And a lot of the things around the media, around DNACPR forms, for example. And, you know, yes, there were some very difficult decisions that needed to be made, particularly at the start of pandemics, when we were really, if you remember back to March, April time, it was a very, very difficult time in which to be involved in any element of healthcare. But I think we have to be really careful how we talk about advanced care planning and its implication on resources. So just sort of flagging that up there. That's great, thank you. We're going to keep going now. I think the other thing is round about what we know of when it can be done, the benefit functions of it. And Ira Bioch did a lot of work in the States in the late 80s, early 90s with HIV/AIDS. So before the retrovirals came. And these were the themes that were coming out of all his interviews with people who really wanted to tell their stories. And without advanced care planning, without the conversations that are open around the fact that death is going to happen sooner than that person might have thought, or death is an inevitability and going to happen. Some of these kind of fundamental bits of us and our personalities and our communities can't happen. Now, you know as well as I know that there are many families who we look after who've got deep-seated, very difficult family conflict and relationships, and we haven't got the time to get to them to this point of closure, if that's the right word, or being at peace with all of these elements. But if we don't even allow them a chance to try, if we don't even encourage people a chance just to try, then I think we're doing people a disservice. And there's something about trying to help that resolution to come, because this will impact on people's grief and people's grieving. So would really recommend, if you don't know Ira Barak, I would really recommend you looking. So, Sian, can you put the next bit on the chat? So when do you have these conversations? So in your practice, or 89 participants, well, 88 if you include me, in your practice, when do you have these conversations? Put something on the chat. We've got significant changes from Sarah, whether it's a hospital admission, actually a patient choice, whether actually people want to talk about it. Karen, when they're ready, when you built a rapport. If people are well enough to process information, Nia, that's a really important point, thank you. And thinking again, yes, if they've been into hospital and have come out and say, right, never again. If they're worried about care. So things are changing, aren't they? And Claire, very important point. Thank you, patient, the needs to have the capacity to discuss. I wasn't going to focus particularly on mental capacity during this talk. In a sense, I guess I'm sort of doing the talk from the perspective of people who have got mental capacity. But if they haven't, I guess it's talking with people who know the person the best. But also kind of, if mental capacity has been lost, for example, because of a stroke or because of ongoing dementia or memory impairment, actually going back to our point when I was asking what we as a group had done for advanced care planning, actually there's something about general society getting on and having these conversations slightly just in case, just so that if capacity is then lost at a later stage, you know as the family member that you are acting on in somebody's really best interests. So it's triggers, isn't it? As you've all said, is it possibly when things change? Is it possibly after another hospital admission? During a conversation about something else? So you might be doing a check, a welfare rights check, or talking to somebody about making a will, and it might be just as part of that conversation. Is there anything else that actually you want to think about? You know, we've talked about a will today, but actually is there anything else that you want to talk to people about? So thinking widely, using all opportunities, being proactive and creative, I think is really, really important. But this is one of Fiona's most used slides. The difficulty we've got is it should never be a tick box exercise. It's a personalised approach. So it should never be on a clerking pro forma, I'm going to ask this, I'm going to ask that, you know, have you got any pain? Have you got any breathlessness? Who's your next of kin? Have you made a will? Da, 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 da. These things are deeply personal. I think probably slightly as evidenced by our own experience within the group. So I think our challenges, particularly in a high pressure work environment, so at the front end of the hospital, in the acute setting particularly, when we've got a high volume of information that we need to collect very quickly, it can be really hard not to actually ask some of these questions and not to make it feel like a tick box exercise. But I think to learn the craft of our work, to learn the skills for communication skills, trying to develop your repertoire, develop your language, that you make people feel at ease discussing it is really, really important. So where do you have it? Well, probably anywhere, I think. If we go by the who and the when, the where is kind of wherever it happens. And that can be quite difficult, can't it? Because actually there are some times when you are in work, when actually for all sorts of other reasons, it's not feeling very comfortable to have tricky conversations with people. And if that's the time when the patient in front of you starts to ask questions, that can be difficult because that's a mismatch. So the patient might be ready, but we're not ready to have that conversation. So I think being aware of that and working out what you would do yourself if you are in that situation, I think is really important. But they can be conversations well handled. They can be conversations that can happen anytime at all, anytime, anywhere, any place. I'm just going to pause just for a moment and ask Karen just to come in here. Just Karen, in your experience, in your role, is there anything that you want to add to what we've been talking about so far? Any other experiences that you want to share?
I think, like you've been saying, it's very personal to every patient that we deal with. Every conversation is very different, and like you mentioned earlier, those patients that aren't willing to go there, we need to document that we've tried to have that conversation, and it might be that they'll have a little think about it and come back at a later date, bring it up with us again, which is always lovely. But it might be that they close down completely and don't want to. And we have to respect that and not sort of almost feel like you're harassing them to get as you say, it's not a tick box, but
yes.
It can be very difficult. And I think having that rapport, like one of the people in the chat mentioned earlier, having that rapport makes it easier because you have that understanding of their body language as well.
Yes, fab. Thank you. And you have just neatly segued me into the next bit of the talk. Perfect timing. And I promise people we didn't rehearse that at all, but it couldn't have come at a better time. Thank you. So who's it going to be? Well, who knows the person best? I think that can be it. If you can do that, but sometimes you can't. Sometimes you happen to be the person on the spot who gets asked the question. I think it's something that all of us can do. If there becomes a particularly challenging situation, then it might be in your team that there is somebody who's built up a particular rapport with somebody, and that might be the natural place for that conversation to go. I think the only thing I would add to that conversation, and I'm about to come on to how we can have the conversation in a minute, but I think what can be difficult, and particularly at the moment, is if you're having an advanced care planning conversation around, for example, preferred place of care and preferred place of death. Of course, this year, with coronavirus, the options of what is able to be provided may be different. So, for example, care at home in the community is there, but it might just look a bit different, and teams may be changing as people self-isolate or have coronavirus themselves. So I think at this point in the year, our communities are probably used to that, but certainly in the early days of coronavirus, that was a really important point to make. So the care is there, it just looks different. But of course, if you're thinking about a care home setting, or if you're thinking about an inpatient hospice setting, or if you're thinking about a hospital setting, the restrictions, the necessary restrictions on footfall, on visiting, makes those places of care slightly different to what they were in January and February this year. And so I think as part of our conversations with people around preferred place of care and death, we've got a slightly different vocabulary at the moment. And it's really important that we help people to understand realistic expectations, however difficult that is. So what's complicated about that is you might be in the middle of an advanced care planning conversation and then actually find yourself thinking, oh, help, hang on, I think I'm about to go into a breaking bad news consultation because the person I'm speaking to was expecting to be able to either go into the local hospice, if you have one, go into a local care home, and actually all the arrangements around those now make it a less attractive option. And so what's left? Where are the family? Can the family come? Very often, no, they can't these days. So being aware of the nuances of the different elements of conversation is really helpful. And again, don't forget, the preferred place of care may not be preferred place of death. So onto the nitty gritty. How do we do it? How do we do it? How do we have these conversations? I'm going to ask for your experience in a moment, but just very quickly, let's just think about communication strategies that can help. And I think for all of us, every once in a while, it's really useful just to take a little bit of time out. It could be an hour, could be an afternoon, if you've got an afternoon. Just think about communication skills. Do it every year. We get into bad habits sometimes just because we don't take the time to think about it. So from all the university courses, we tend to use a model of the Cardiff 6-point toolkit, which Nikki Pease, our colleague, wrote about in 2017, although Nikki and Joe and colleagues running the course earlier on in about 2008 developed the concept. And it's really just a collection of tools that help in any conversation. So it's not a breaking bad news, it's not advanced care planning conversation particularly, but these tools can help. The thinking around these skills, it is very fundamental skills of, is the person comfortable physically and psychologically? Are you comfortable? Are you hungry? Are you stressed? Yes, probably, because life is a bit busy at the moment, but you need to feel comfortable and at ease. Think about your language, both what you say and how you are. Do you look at ease when you're talking with people? Talked a bit about question style. Open questions which haven't got a yes/no answer are useful, but as we've seen with Ruth Parry's work, actually people can potentially avoid the conversation if they don't want to go there. But the hypothetical questions are useful. Have you ever wondered if? When we're anxious, very often, and nervous, very often we will talk quickly, and very often we'll ask more than one question at a time. That's not helpful because people will answer the last one. So try if you can and just ask one question at a time. Listen to the skilled interviewers on the radio. Skilled interviewers ask one question at a time. Those that are learning or those that are a bit anxious ask more than one, and they'll only get one answer. Listening, I'm coming on to in a moment. Reflecting back is a useful skill. So if you think about that need to respond to cues that patients give you, if they have a particular word, for example, they might say, I'm a little bit worried about my wife. So rather than ask another question, so what is it about your wife that you're worried about? Just use one word and just reflect, oh, worried? And see what happens, because that can sometimes then prompt the next lot of information to come. So reflecting back is literally what it says it is, reflecting back what you're hearing, and then summarizing, really useful skill for any consultation. Listening and talking in a classic consultation, we should be listening 80% of the time and talking for 20%. I don't do that on a busy day. When I'm thinking about it and it's a really important conversation, I try to. I might get to 70-30. I'm not sure I get to 80-20, but there is no doubt that if you are quiet as the healthcare professional, people will talk to you. And the interesting thing that listen and silence share the same letters. One of those quirks of language. One of the things that people get very worried about is silence. And particularly when you're busy and when you're working in a high pressure environment, silence can be very difficult because your brain is going on, your heart rate's probably going on, you've got 15 more people to see in the next hour. You've got time to be silent. But if you hold your nerve, particularly if there is something really important that has to come out, like a preferred place of care, or perhaps more importantly, a preferred place of death, if you can hold your nerve and be silent, and people are struggling with internal worries, very often what falls into the plate, what comes into the gap that the silence has created, is the most important thing for that person. So again, it is tough in the high pressure environments. I know that, I have also worked there. But for having that skill and beginning to recognize when that skill is useful can unlock all sorts of things, which then unlock the key to people's future care. And actually then that's time well invested, because it's then a smoother transition to where they might want to be. We can talk about, we can do communication skills for a whole nother series of webinar. It's fascinating. So again, this is just a summary, a little bit of, again, hypothetical questions some people find, respond to people's cues, check back and summarize. But knowing when to pause and stop is also really important. So that's linking into what Karen was saying. So Sian, can you put the next question on the chat, please? So have a think, folks. How do you know you're deep in your conversation, or you've asked that first hypothetical question? How do you know if the other person is feeling uneasy? How do you know if this is a safe area to go to? Body language, restless, eye contact, possible anger, tone of voice, break eye contact, fantastic. Change expression. Change expression, that's really interesting, because actually you're right. It's not always people start to get restless. Sometimes people who previously have been a bit restless will go completely still because they freeze, because they're just about to think about something, or they think you need to be talking about something that they feel deeply uncomfortable with. Oh, a lovely phrase there. Ask if it's okay to go into the topic. Absolutely right, Bina. That's a lovely way to think about it. So again, what I would be doing is to just be watching and listening, everything on high alert, and just to say, I can sense that you're uneasy with this conversation. Is it all right if we go on? And then sometimes people will say yes, sometimes people will say no, but you're building those building blocks, as Karen was saying, which is so very important. Thank you. Do keep contributing to the chat, but that's really fundamental. When you're teaching new colleagues alongside you all of these skills, this is your safety net. How do you know when to stop? I think it's really, really useful to reflect on that. So, and what's COVID done? Well, COVID's had a fundamental impact, hasn't it, really? I think COVID has brought advanced care planning into sharp focus as a need, because COVID affects anybody. It doesn't seem to distinguish between people. It's affecting place of care, it's affecting place of death, it's affecting care arrangements, but also it's affecting us, and it's affecting how we can communicate with people. I think I've got another, haven't I, Sian? I've got another chat. Very quickly on the chat button. How's COVID affected you and how you have these conversations? I'm conscious of time. We're going to be okay. We are going to finish on time. But COVID has done incredible things for communication. Not all bad. Remoteness, Suzanne, that's a really lovely word. Remoteness, difficult not being face to face. Claire, in some cases it's been easier. It's not all bad, is it? PPE, face masks, Sarah, absolutely. About families visiting, so that connection with families is difficult. Less face to face, time pressures, face masks, fantastic. Keep those thoughts coming. Keep those thoughts coming. I think we would be disingenuous if we did not think that COVID has had an impact. Of course it has. As we've said, on all elements of advanced care planning, it's not always bad. There have been opportunity for a different sort of access, but actually thinking about how we can make these communication skills still work in the virtual world, whether it's phone, whether it's video consults, and this is a picture of me with an actor patient. You can still use some of the tools that the Cardiff 6-point toolkit has illustrated, but you just need to adapt them slightly differently. So who's there in the room with the person? If they're on the phone, do you know who else is in the room? Is it an all right time to speak? Have you made an arrangement to speak, or are you ringing out of the blue because of a particular issue? If you're on video, they see this bit of you. So your facial expression, your facial language is in sharp focus, but I know you're not in the same room as the person, but they can see all of you. Whereas with PPE on, they can't see all of you. So it's just a question of where is it going to be best to have the most fruitful advanced care planning conversations. Question style is no different. Listening can be really hard with delays virtually, and particularly on the phone when you're getting no cues back. But if the option is to not have any of this communication at all, this is better than nothing. So it's about being understanding where the challenges are of the different conversations. And thinking around PPE. PPE has been very difficult for many people this year in the community. We don't have all the big stuff that you do if you're working on intensive care units or on a COVID ward, but we are wearing masks and visors, and for me, I've got my reading glasses, everything steams up and I can't see. So I'm supposed to be having deep, meaningful conversations with people with my head tilted back, not feeling comfortable, and I can't see them because I'm all fogged up. That's really difficult. You do the best you can, but it does make it challenging. However, it does mean that we are out there and we are seeing people. There's been lots of talk. There's some really lovely stuff on YouTube. Look at Claire Atkinson's video on YouTube about how to make this bit of you compassionate. So it's about how you use your eyes behind the mask. Do you warn people that you're going to be wearing PPE? Do you have your name badge on wearing PPE? We haven't got time to ask you what you all do to help make PPE more approachable, if you like, but if you want to put that on the chat, then do please feel free to put that on the chat. But I think the purposes of these two slides are really just to say it is different. It is different, but it's really important that we work with these differences to continue to have these conversations. And I think just the other bits that can help with having these conversations is actually, are you ready? Can you be, for the moment that you're with that patient, whether it's for a couple of minutes, whether it's for 10 minutes, whether it's for longer, can you really try to put everything else that's going on in your world out to one side and just focus on that person and their issues in front of you? It's really tough to do that some days. I find it really tough to do that some days. But when I can, I know that those conversations have been at the pace of the patient and we've really got that information that we need, and I have helped somebody to crystallize their thoughts a bit further as to what they want to do. So can you be in the present? Think of your question style. Having a proper reason, as we said before, can sometimes help. Can we help public awareness? Actually, can we contribute to the, you know what, actually it's a really useful thing to chat to somebody who, you know, somebody who's important to you about what you might want if it happens to you. So again, going back to what our experience in the group is, just something just to make you think. I've put time in the brackets right at the bottom there, because I have witnessed some ACP conversations that have been undertaken in 2 or 3 minutes at the front end of the hospital, and they have achieved more than 30 minutes of beautiful, wonderful solitude with me and the patient. So I think time, yes, it is very difficult to have meaningful conversations in 30 seconds, absolutely. But in fact, I think sometimes we use time as an excuse not to start them. And I think sometimes we, me included, we'll miss opportunities. So an awareness of time, yes, it's easier if you have lots of time, but in the current situation, very few of us are working in situations where we've got lots of time. It's a high pressure world out there. So think about how you can maximize the time. Think about what should get written down. So actually, is it a legal document? So an advanced decision to refuse treatment is a legal document. Wills, lasting power of attorneys are legal documents. So what could get written down, what should get written down? 2 slightly different questions. Anything else written down is helpful. Things about statements and wishes. If you're working in England, then you'll have things like the respect form. We've got slightly different forms in Wales. Wherever you work in the world, you might have slightly different processes. But documenting something somewhere is better than having nothing documented. But as Karen was saying before, actually, if you can't have the conversation, it's also useful to document how far you've got in that process. And what happens next? Who needs to know? So the next thing to put on the chat is just, I'm interested, do you have a central point where you work? Do you have a central point of information where you could access any advanced care plans for people who you look after? And I'm just interested because every area is slightly different. Because you would think it would be great, it would be easy, wouldn't you, in this day and age with technology? One point, everything goes there. It's not quite so easy as all of that. So I'm just fascinated in case everybody says yes. Right. So Wales, where I don't think there's a secret plan. Patient notes, Welsh clinical portal in Wales, all being well, should be, hopefully, fingers crossed. London coordinate my care, e-system. GP systems, documents, intranets, nurse office, no. Okay. So it's really difficult, isn't it? And I think this is a wonderful area of opportunity. And I know that there are, and probably many of you on the call today are working on this. We do need to keep the pressure on to try to find a safe, central place to document it. I think one of the problems is that we do need to revisit it. And sometimes if people change their mind, the anxiety is that the advanced care plan documentation may not change to reflect people's changing of mind, because some situations do change. So there's a lot of very difficult issues to think about. Having said that, finding some way to make sure that the people who need to know is really important. And for us to revisit things is also really useful. And so, you know, do you remember when we talked, do you remember when you went into hospital before and you came out and you said, is that still the same? You can ask very general questions, I think, without causing too much distress. But last few moments now, one of the last chats, an ultimate chat this is. So Sian, if you could put this on the chat function, what do you do? What do you do in your practice if people don't want to talk about it? So you ask all the right questions, you've got your comfort set up, it looks as if it's going to go really smoothly. What happens? Suzanne, great response. Accept and respect. Accept and respect. Expect, keep the door open. Try another time. Fantastic, absolutely right. It can be really hard though, can't it? Especially if you've spent a lot of time working up to this point. And yet it's still not there. But actually, if you push it, potentially you can cause more distress and you can keep a door more firmly closed at a time when actually it needs to be opening again. So all of these things, thank you, they are really important. But sometimes, particularly with junior colleagues, if you're teaching people about this stuff, you almost need to give people permission to not go further, because they're supposed to go and talk about advanced care planning because that was their mission, but actually it's not going to work. So document where you've got to and come away, but we have to respect people's wishes. So I sometimes also think of if it's a difficult conversation, actually, is it me? You know, am I just not in the right place? My favorite slide, am I hungry, angry, late or tired? For all sorts of reasons. Because if you are hungry, angry, late or tired, your decision making, your cognitive ability is not going to be at its best. So is it something in me? Is it a bad day for me? What do I need to do to get that sorted pretty quick, or else the day is going to continue to go badly? Is it something to do with the patient? Is it the setting? Have I just got the timing wrong? So just a bit, not too much analysis that stops you from doing anything else, but just a little bit of, okay, ooh, that didn't go how I thought it was going to go. What do we do? What is the urgency? Can it be revisited? There are some conversations, spinal cord compression, needing to get radiotherapy, urgent cardiovascular situations. The paramedics in the group will be able to tell, you can tell us all sorts of urgent things when actually you just need to get on, ask the question and get a plan of action. But for quite a lot of situations, does it matter? Or can we use time and do these building blocks? And it's where you're at with other team members. And so sometimes, certainly people in Cardiff who I ring up when I've gone to see people as a first assessment, so GPs in the group, you know, you'll know that sometimes I'll ring up and say, well, I got this far, but it was a first assessment and it just, you know, I couldn't get past that first. I think we just need to be able to come back into this house again. So what I need you to do in the last few minutes, just again on the chat, Sian, if you could put our last chat, just out of interest, what's going to change? You've been a fantastically interactive group for the last hour, and I've really got a sense from the chat that this is something that we're all battling with, if you like, and having this incredible experience. But what's going to change as a result of the last hour? What's going to change in your advanced care planning practice? Just spend a quick moment and just think about that. And as you're thinking about that, I am going to say, here are some useful resources, and we'll send these slides out to you. There's lots of resources out there. There's lots of toolkits, lots of packs, both on what constitutes advanced care planning and documentation, but also some really useful tools on how to have the conversations, a little bit like what we're speaking about. And here is the information for our next session. We've probably got about 5 minutes if we can for any questions and answers. So I'm going to stop talking now and see if there's anything else that people want to ask.
Yeah, if anybody wants to type any questions into the Q&A, we've got the panel here, we can grill them for you, so type them in quickly.
And anything else that's come up in the chat. And Sian, is there anything on the chat sort of that's been a theme that sort of has come through that you've noticed?
No, not specifically. There's some wonderfully thoughtful responses that have come through, which has just been fantastic, and I'm sure everyone will enjoy reading through them afterwards as well.
Right. And Suzanne, thank you. You've just commented the chat has now been disabled. So please, my email is there, our Twitter account is there, Charlotte's Twitter account is there. Please do feel free to get in touch with us if there is anything else that you want to ask.
Yeah, type them into the Q&A. We've got a couple here, Fiona. How do you deal with mental health issues in ACP?
Thank you. That's a really good question. I think part of the mental health assessment, if you like, is the double checking as you start that the person has got the mental capacity for the task in hand. So if you look at the Mental Capacity Act, it's very much task specific. So somebody might not have the mental capacity to decide what they want to do about their possessions, about their belongings, about making a will, but they would have mental capacity to say, yes, no, I would have antibiotics or I wouldn't have antibiotics. So I think before some of the more complicated collections of issues, I think if you're wondering about mental capacity, it's worthwhile just checking mental capacity. If you're thinking about mental health issues regarding, for example, anxiety or depression, and that fear that if you start talking about this, you're going to adversely affect people's mental health, I think that goes back to the skill in starting those open questions and your safety net as to how will you notice if somebody is uneasy about the way the conversation's going. Karen, can I bring you in on this one? Is there anything that you want to add to that?
Yeah, just exactly what you were saying about the fact that just because they can't manage their finances doesn't mean that they can't tell you that they really don't want to go back into hospital. And if they can show to you that they understand the meaning of that to them, and it might be they don't want to leave their cats, they'd rather be in their own room with putting their own music on and things, then we should try to. What's that thing that we always presume people have capacity unless they show us otherwise, that so we should be listening to them and not saying, oh, but I know they've got dementia, I don't, so I'm going to make this decision in their best interest. And I think it's that paternalistic view that we sometimes have in sort of our roles, that we need to avoid that and listen to them and make them get heard somehow, and by the paperwork, hopefully, so we can do that.
And that you've made me think of another thing to add to that, which is that if it's a mental capacity that is going to change, for example, as a result of dementia, then those of you, if any people on the call have worked with part of memory clinics, you know, actually part of the art, if you like, is in trying to get people's wishes at a stage before they begin to lose mental capacity for some of these issues. So again, the public awareness of the need to talk to those people who are important to us about the things that are important to us actually is an everybody thing. It's not just the people we look after, it's us as well.
I have another question, Fiona, and the rest of the panel. Is there a resource you can suggest to signpost patients to around ACP?
Oh, now, that's a very good question. I'm going to think about things like the NHS Wales site. I'm going to think about places like if you're thinking about DNACPR, which we haven't specifically discussed today, just because there wasn't particular time, we could do that at another time. The Resuscitation Council has got some very good patient information leaflets. Organisations such as Dying Matters, if you can get past the name, will have very good information and leaflets. Again, Karen or Emily, are there any other sites that you're aware of? The Respect site for England, I think it would also be a very good one, and there are patient resources. Anything else?
For any local GPs, the Cardiff Clinical Portal, there's a page gone up. If you look under GP information and resources and scroll down to P for palliative care, there's a link to the primary palliative care page, and that is laid out. There is an ACP section, and there are resources for healthcare professionals, but there are a few patient leaflets as well. There's one from the NHS on there, the DNACPR leaflet is on there, and there's a link to a couple of others, things like age concern and things on there, so have a little look there.
And I would say we also have the Advanced and Future Care Planning intranet site on Cardiff and Vale. So if you are within Cardiff and Vale, I'm not sure where this person is working from, you can access that, and it has the link for Emily's page and link through to mental capacity and forms and resources on there as well.
There we go. And that, yes, I think that's what the website looks like, isn't it? I think I was on it yesterday on there. So fab. Thank you. Thank you. Great. There we go. Anything else, Charlotte?
I think we'll squeeze one more question in before we start losing people. Any advice how to communicate with relatives who demand treatment or hospital when this is against the wishes of the patients expressed in their ACP?
Oh, gee, that's a cracker, isn't it?
How long have you got?
Yeah, I was going to say, should we do another webinar? I think go carefully. I think where the conversation goes and how quickly it might take to get some kind of resolution sometimes depends on the gravity and the acuteness of what's happening. This year particularly, we've got a problem, haven't we? Because families have been much more distant. So, for example, I know what my mother looks like on Zoom, but I've no idea what her mobility is like because I'm not physically in the house watching her because she doesn't live in Wales, so I can't go and bubble with her. So families are not as close together, so they're not getting the visual cues, which means that when decisions about care, when decisions about treatment, and when I say care, I mean care arrangements, or decisions about treatment are made or are being discussed, they are often not at the same page. They're not in the same place as and it wasn't perfect before, but I think COVID has made it particularly difficult. And I think what can be very difficult is if there is absolute conflict. So if the patient has got, and even sometimes if the patient has got a formal advanced decision to refuse treatment, a legal document, but the family is in disagreement with that, that's a particularly difficult situation. I think all you can do in those first moments when you hear that there is a conflict is listen. And it's very often, I think, why is there conflict? And it's very often, not always, but very often because the families are distressed. They're facing loss. They're facing their relative dying at some point, and death is death. We can't make it anything other than the fact that that person is not going to be there anymore. And if relatives are not there, have not confronted it, have not begun to think about it, it's deeply distressing, and they will then fight anything that will seem to make things happen sooner. So what can you do? You can explore what their fears are. You can explain what is going to happen. And very often, I'm going back to ceilings of treatment and ceilings of care, very often people are just worried that everything is going to disappear. And in fact, no, if you can explain what is going to happen and the care arrangements that are there, then sometimes you can start that process. But basically, you've got people in different places, and you need to try to use time, if you can, and bring them together. If you can, it's best to try to avoid out and out conflict. And inside, you might be thinking, we've got a legal document that says this person does not want this, and you as a family can't contest this is that legal document, but you can't. You know, you have to think that inside, and you have to find your body language and your words that will come out and will try and support more conversations. Karen, very quickly, because I can see people need to go off through things, but have you got any advice as well? How do you deal with that?
I think exactly what you've said, and just bear in mind that this family will be dealing with this after you've left the room, so you have to leave them in a state that there are bridges that can be built afterwards. That's all I would say.
That's a really good point to end on. Thank you. Absolutely.
Thank you very much. Is there anything any of the panel want to add to that, or any final words from the panel?
Emily.
Thank you all for attending.
Yes.
It's amazing.
Joe Hayes and Sian, is there anything quickly that you want to add that we haven't covered?
No, I don't think so. I have put a YouTube link to Clea Atkinson's communication stuff on the chat if anybody wants to go back and have a look at that.
Brilliant. Thank you. Really good. Thank you.
Thank you all. This reminds me to thank you for the panel today, and thank you all for attending. And we will be evaluating the session, sending out some evaluations, and I really encourage you to fill them in, because it will give us some momentum to maybe offer some of these again in the future. And that's enough for us today. Hopefully see you all in the next 3 weeks. Take care, everyone.
Thanks, everybody.
Bye.
Bye now.